Imagine the relief. You're in the emergency department. You've been doing CPR on a patient for what feels like an absolute eternity, and finally,
You feel it.
yeah, right beneath your gloved fingertips, you feel a pulse.
It's ROSC, right? Return of spontaneous circulation. I mean, it is the exact moment every single clinician in their room has been fighting for.
Exactly. But before you can even take a breath or, wipe the sweat off your forehead, the monitor just starts screaming again. The patient's blood pressure is plummeting.
And suddenly all that initial relief just evaporates because this is a terrifying yet incredibly common reality for you in the ED.
How common are we talking?
Depending on the data you look at, it's anywhere from 50 to 70% of cardiac arrest survivors who experience this massive post-resuscitative shock. Like, the heart is beating, but the cardiovascular system is just collapsing.
Right. So you're standing there staring at those dropping numbers, and you have to make a split-second decision. You need to start a vasopressor to squeeze those blood vessels and keep the patient alive.
Right.
But which one do you reach for? Because this seemingly simple choice completely alters the trajectory of a patient's recovery. And for this deep dive, that is exactly the critical decision we are exploring.
It really is the million-dollar question in post-ROSC care.
When that post-arrest hypotension hits, do you reach for the classic standby epinephrine? Or do you pivot to norepinephrine?
It's a debate that, honestly, it forces us to question some very ingrained habits in emergency medicine.
Yeah, and we have some incredibly revealing data to parse through today for you. We're looking at formal evidence, ranging from large, multi-center observational data, specifically the 2022 Bougouin et al. Study.
Yep. And the Optimus CC trial from Levy and colleagues in 2018.
Exactly. Plus a brand new 2025 Williams et al. Meta-analysis. And spoiler alert, they all point toward a massive shift in how we should be handling this super fragile post-arrest period.
They really do.
But before we jump into the clinical trials themselves, we should probably establish the baseline physiology.
Yeah, that's crucial.
We need to look at what these two drugs actually do to a freshly revived, highly vulnerable heart, like on a cellular level.
Right, because to understand the difference, we really have to look at the pharmacology of what happens when you introduce these medications to a stunned myocardium.
A stunned myocardium.
Yeah. A heart that has just been in cardiac arrest has been totally deprived of oxygen, right? And ironically, getting a pulse back is when a lot of the damage actually happens through reperfusion injury.
Wait, I want to pause right there because that sounds kind of counterintuitive. Getting oxygen back to the tissue is the whole goal, isn't it? How does returning oxygen cause damage?
It is the goal, but it has to do with how the cells handle the sudden influx of oxygen after being totally starved of it.
Okay.
During the arrest, the cardiac cells become ischemic. Their normal metabolic pathways just shut down. When you suddenly blast that tissue with a fresh supply of oxygenated blood upon getting ROSC, the mitochondria essentially, well, they misfire.
Misfire how?
Instead of creating energy, they produce this massive abundance of reactive oxygen species, free radicals.
Ah, right. And free radicals are highly unstable molecules, right? Like they are missing electrons.
Exactly. They're missing electrons, so they violently strip electrons from the nearest available source, which is usually the cell membrane itself.
Yeah.
Yeah, it literally shreds the structural integrity of the cardiac cells. So you have this heart that is currently undergoing massive cellular trauma.
Okay, so picture that heart. And if your reflex is to start an epinephrine infusion to fix the dropping blood pressure,
Which is what a lot of people do.
right, you are hitting that already traumatized heart with potent beta-adrenergic stimulation, specifically beta-2 stimulation.
You're driving up the tachycardia, demanding way more myocardial oxygen consumption at the exact moment the cells are actively destroying themselves from that reperfusion injury.
So you are forcing this highly damaged, oxygen-starved heart to suddenly work much, much harder.
Exactly. And the beta stimulation also floods the cardiac cells with calcium. So this combination of structural damage from free radicals and massive calcium overload, it creates a highly toxic phenomenon.
And this is what the literature calls the epinephrine burden, right?
Yes, the epinephrine burden. It's a state of severe catecholamine-induced cardiotoxicity. You get severe proarrhythmic effects.
Meaning it causes dangerous heart rhythms?
Right. Basically, the drug creates an incredibly unstable environment that can very easily trigger another cardiac arrest.
Which is exactly what you just worked so hard to fix.
Exactly.
So how does norepinephrine avoid doing the exact same thing? I mean, it's still a potent pressor.
It is, but it works entirely differently. Norepinephrine is predominantly an alpha-1 agonist. It has almost negligible beta-2 activity compared to epinephrine.
Okay, so if it's primarily targeting alpha-1 receptors, does that mean it largely bypasses the heart muscle itself and just goes after the peripheral vasculature?
That is the crucial distinction, yes. It tightens the blood vessels to raise the mean arterial pressure, the MAP, without directly forcing the heart to beat faster or contract with more explosive force.
So it achieves the goal. It raises the systemic blood pressure.
Right, but it avoids causing that severe metabolic derangement in the cardiac tissue.
To put a visual to this, using epinephrine right after an arrest sounds like dealing with an exhausted horse that just finished a marathon.
Oh, I like that analogy.
Right, like you need to keep moving, and epinephrine is essentially whipping the horse. You might get a surge of speed for a second, but it is going to collapse.
It's going to give out completely.
Yeah, but norepinephrine is more like just tightening the reins so the horse stays on the path without having to sprint.
That is a very accurate way to visualize the mechanism. You are providing structural support to the system, tightening the reins, without demanding more output from an already failing pump.
Which makes perfect sense in theory. But, we've seen plenty of physiological theories fall apart when they finally meet real patients in the ED. Do we have clinical data that actually matches this textbook pharmacology?
We do, and honestly, the data is striking. We should look at the Optima-CC trial, published by Levy et al. In 2018.
Okay, let's dive into that one.
They wanted to test these exact drugs on highly stressed, failing hearts. Specifically, they looked at 57 patients experiencing acute cardiogenic shock immediately following a myocardial infarction, a heart attack.
So this is testing the exhausted horse analogy directly. You have a heart that has literally just suffered an infarct, the pump is failing, the pressure's dropping. What actually happened when they randomized them?
Well, the results were so dramatic that the Safety Monitoring Board actually had to intervene and terminate the trial early.
Wait, terminated early. You rarely see trials halted early. Usually that means someone's getting hurt.
Unfortunately, yes. The patients in the epinephrine group were deteriorating rapidly. They experienced sustained tachycardia, which, we expected based on the beta stimulation.
Right.
They also had significantly delayed lactate clearance, meaning their bodies were struggling to clear the acid building up from poor systemic perfusion. But the absolute most alarming finding was the rate of refractory cardiogenic shock.
Refractory meaning they're spiraling completely out of control, and no amount of medication or intervention is bringing their pressure back up.
Right. They are unresponsive to treatment. In the norepinephrine group, the rate of refractory shock was 7%.
Okay.
But in the epinephrine group, it was 37%.
37%. That is, wow. That is more than 1 in 3 patients slipping beyond the point of no return, simply based on which PIPA bag was on.
It is a 5-fold higher rate of refractory shock. It proved, in real time, the clinical danger of the epinephrine burden on a struggling heart.
The beta stimulation was quite literally working these damaged hearts to death.
Exactly.
But hold on, I'm thinking about the parameters of the Levy trial, and there is a pretty massive caveat here for our listeners.
What's that?
They looked exclusively at cardiogenic shock caused by a heart attack and have a broken pump. But undifferentiated post-cardiac arrest shock, which is the massive post-resuscitative crash we were talking about today, that's a total wild card.
That's true.
You don't always know why they arrested in the field.
Ah.
Sometimes it's a massive PE, sometimes it's vasodilatory shock from systemic inflammation that mimics sepsis. So can we really take a 37% failure rate from a pure heart attack study and map it onto the post-ROSC patients we're focusing on?
That is a vital distinction, and it's a necessary pushback when interpreting clinical trials. You cannot just blindly extrapolate data from one specific pathology to a highly heterogeneous population like post-arrest patients.
Because it's just too messy.
Right. The physiology of post-arrest shock is incredibly messy. It can be vasodilatory, cardiogenic, or a mix of everything.
So why are we talking about the Optima-CC trial if the patient populations don't exactly match?
Because post-arrest physiology almost universally involves severe myocardial stunning. Regardless of whether the initial cause of the arrest was respiratory failure or an arrhythmia, the heart stopped. It was deprived of oxygen, and upon ROSC, it undergoes that aggressive reperfusion injury we discussed earlier. The underlying mechanisms of a stunned, failing heart overlap significantly with cardiogenic shock.
So the mechanics are similar enough to raise a huge red flag.
Exactly. But your skepticism is shared by the medical community, which is why researchers didn't stop with the Optima-CC trial. We have data specifically targeting the exact patient population you were asking about.
Oh, perfect. Did someone actually test this specifically on out-of-hospital cardiac arrest patients? Like the people whose hearts stopped in their living rooms or at the grocery store?
They did. We can turn to the 2022 Guggenheim Multicenter Study. This was an observational study out of France, and it looked exclusively at 766 out-of-hospital cardiac arrest patients who developed post-resuscitation shock.
So this isolates the exact demographic. EMS brings them in, we get a pulse, the pressure tanks. What did they find when comparing the two drugs in this specific group?
The results were stark. They found that epinephrine was associated with significantly higher all-cause hospital mortality. The adjusted odds ratio was 2.6.
Wow.
And when they looked specifically at cardiovascular mortality, meaning death from a repeat arrest or unrecoverable hemodynamic collapse, the adjusted odds ratio spiked to 5.5 for the epinephrine group.
5.5 times higher odds of dying from a cardiovascular event. That's massive.
It is. And we also have to consider the brain. Surviving is one metric, but functional recovery is the true goal, right?
Absolutely.
The neurological data was equally devastating. In the norepinephrine group, 37% of patients had a favorable neurological outcome. In the epinephrine group, only 15%.
37% down to 15%. That is a huge drop in patients actually waking up and returning to their lives.
Yeah.
But, okay, let me put on my skeptical researcher hat for a second and to challenge the methodology here. You mentioned this was an observational study, right?
Yes, that is correct.
It wasn't a randomized trial where people were assigned a drug blindly?
No, it was observational.
Then isn't there a glaring risk of indication bias here? What do you mean? Well, if I'm an ED physician and EMS brings in a patient who has been down for 40 minutes, their initial pH is wildly acidic, they're barely clinging to life, I might reflexively reach for epinephrine simply because it's considered the heaviest hitter, right?
Right.
So the drug didn't kill them. The fact they were practically dead on arrival killed them, and the epinephrine was just a marker of a desperate clinician.
That critical eye is exactly how observational literature needs to be dissected. And in the raw, unadjusted data of the Buckhorn study, you are absolutely correct.
Okay.
The epinephrine group was sicker at baseline. They had a longer time to achieve ROSC. They had higher initial lactate levels, and they had lower, more acidic pH levels upon admission.
So the data is skewed. We're blaming the drug for the fact that the patients were already too far gone.
Well, the researchers anticipated this exact confounder. To account for that indication bias, they used a rigorous statistical method called propensity scoring.
Ah, propensity scoring. Break down how that actually fixes that kind of bias without physically randomizing the patients.
Think of it like creating artificial twins in a database.
Okay.
The statisticians calculate a propensity score for every single patient based on their baseline sickness, their age, their downtime, their initial rhythm, their pH, their lactate, all of it. Then they take a patient who received epinephrine, let's say a 65-year-old with a 25-minute downtime and a pH of 7.0. They search the massive pool of norepinephrine patients to find a demographic and physiological match.
So you discard the outliers and only compare the patients who were equally sick when they rolled through the doors.
Exactly. By matching these incredibly similar patients, they essentially strip away the sickness factor. You're comparing apples to apples.
And what happened after they matched them?
That's the alarming part. Even after applying this propensity matching, even after adjusting for exactly how sick the patients were at baseline, the massive mortality spike associated with epinephrine remained. Yeah. The drug itself remained an independent, highly significant predictor of death and poor neurological outcome.
So the physiological theory of the epinephrine burden causing chaos holds up. The Optima CC trial showed a 37% failure rate in pure cardiogenic shock. And the Buckhorn study confirms a massive spike in cardiovascular mortality and brain damage in out-of-hospital arrest patients, even when accounting for baseline sickness.
Yes, the evidence seems to be stacking heavily in one direction.
It really does.
But, in evidence-based medicine, relying on single trials or observational cohorts always leaves some room for doubt. To definitively shift practice, we need a bird's-eye view.
Right.
We need to aggregate all available data, which brings us to the most robust piece of evidence we have.
Well, let's hear it.
The 2025 Williams et al. Meta-analysis. This is the largest, most recent, and most comprehensive synthesis of evidence on this exact topic.
Brand new data.
Exactly. They combined 6 different studies, pulling data from 3,458 patients.
Wow, okay. A data set of over 3,000 patients provides serious statistical power. What was the defining metric they uncovered?
When aggregating all of this data, The Williams meta-analysis found that norepinephrine is associated with a 63% lower odds of recurrent cardiac arrest compared to epinephrine.
Wait, a 63% reduction in arresting again?
Yes. And crucially, this benefit was most pronounced in the out-of-hospital cardiac arrest population.
A 63% reduction is undeniably huge. But I was reviewing the secondary endpoints of the Williams meta-analysis before we recorded, and I noticed a statistical nuance that might confuse some clinicians.
Which endpoint?
The study explicitly notes that when looking at overall survival to hospital discharge, there was no statistically significant difference between the two drugs.
That is what the data showed, yes.
So if a skeptic looks at this, they might say, well, if the patients ultimately survive to leave the hospital at the exact same rate, regardless of which IV bag I hang, why should I bother changing my practice?
Right, I've heard that argument.
If the endgame mortality is technically the same on a spreadsheet, does the drug choice really matter that much?
That question cuts to the core of what we value in critical care. The answer requires looking beyond a binary alive or dead column on a spreadsheet and understanding the profound devastation of a recurrent cardiac arrest.
Okay, unpack that for us.
Preventing a second code is a massive, incredibly valuable, patient-centered victory, even if the ultimate discharge mortality numbers don't show a statistically significant gap.
Walk me through the actual impact of that second code. Because if they survive it anyway, why is it such a vital metric?
Think about the collateral damage, both physiological and operational. Physically, when a patient loses their pulse again, you are resuming aggressive chest compressions.
Right.
You are causing further trauma to a sternum and ribs that have already been fractured. You are pushing massive code doses of medications that further derange the cellular environment. But most importantly, you are causing a second profound hemodynamic collapse.
Ah. So the brain is starved of oxygen all over again. You are compounding the anoxic brain injury they suffered during the initial arrest.
Exactly.
Yeah.
You are resetting the clock on their cerebral perfusion. Every second they spend in that recurrent arrest diminishes the chance they will ever wake up as the person they were.
That's horrifying.
It is. But beyond the physical trauma to the patient, consider the operational reality of a second code in an emergency department.
It's chaos.
It requires immense hospital resources. It pulls multiple nurses, a respiratory therapist, and an attending physician away from the rest of the department, which is usually full of other critical patients, for another hour of chaotic resuscitation.
Not to mention the family.
Right. It severely traumatizes the patient's family who had just been told their loved one had a pulse.
So survival isn't a flat metric. Surviving after a smooth stabilization is entirely different from surviving after crashing 3 more times, requiring massive interventions and sustaining further brain injury.
Precisely. The Williams data proves that norepinephrine drops the risk of that chaotic, damaging second arrest by 63%. It provides a stable bridge for recovery.
Returning to our horse analogy, or well, let's use a car analogy this time. The car might technically get towed across the finish line either way.
Right.
But with epinephrine, the engine catches fire 3 times along the route, requiring an entire crew to put it out and rebuild the engine block. With norepinephrine, the car just rolls steadily into the shop.
That visualization captures the clinical reality perfectly, which brings all of this, the cellular reperfusion injury, the early trial terminations, the propensity scoring, and the meta-analysis into a concrete, actionable framework for you, the listener.
So let's establish that framework. We've covered a dense stack of pharmacology and statistics. What is the definitive clinical bottom line here? If a clinician is standing in the resuscitation bay and finally feels that pulse, what is the protocol?
The definitive takeaway for emergency medicine is this. Default to norepinephrine as your first-line vasopressor for post-ROSC hypotension.
It seems like the data overwhelmingly supports that shift. Do the major governing bodies agree yet?
To be fully transparent with the formal guidelines, the 2025 American Heart Association guidelines currently state that there is insufficient randomized controlled evidence to issue a rigid Class 1 recommendation mandating a specific vasopressor.
Okay, so no Class 1 mandate yet.
Right. However, they explicitly note within the guidelines that epinephrine is associated with an unfavorable safety profile in this exact population.
And guidelines often lag behind the bleeding edge of meta-analyses, but even they are flashing warning signs about epinephrine's safety profile.
Exactly. The overarching consensus in the literature strongly dictates moving away from it. And practically speaking, implementing this means breaking a very deep-seated reflex in emergency medicine.
Because it's just so easy to use what's already there.
Right. During the chaotic minutes of a cardiac arrest, you are often pushing bolus doses of epinephrine every few minutes. When you finally achieve ROSC and the pressure drops, the absolute easiest, most frictionless thing to do is to simply hang an epinephrine drip.
The drug is already drawn up, it's in the room, it's in your hand.
It's the path of least resistance during a highly stressful, adrenaline-fueled moment.
So we have to actively resist that reflex.
We do. Do not reflexively transition the push-dose epinephrine used during the code into a continuous infusion post-ROSC. Take the extra 60 seconds, communicate clearly with your team, switch gears, and start a norepinephrine infusion.
It is the empirically proven method to stabilize the hemodynamics, maintain perfusion, and avoid the dangerous arrhythmogenic epinephrine burden.
It's about taking a breath in the chaos, recognizing that the patient has entered a completely new physiological phase, and making the active choice to protect the stunned heart rather than just hitting the gas pedal again.
It requires a fundamental shift in how we view the post-arrest period.
Yep.
It is not just an extension of the code, it is a highly delicate recovery phase.
Perfectly said.
Well, this has been an incredibly revealing deep dive. We've gone from the chaotic destruction of reactive oxygen species on a cellular level through the premature termination of the Optima CC trial, unraveled the statistics behind indication bias in the Bugern study, and landed on a very clear, actionable clinical shift backed by the 2025 Williams data that can genuinely save patients from a second traumatic arrest.
It's a lot to process, but it's practice-changing.
But as we wrap up, I want to leave you, the listener, with a final, slightly provocative thought to mull over.
Oh, I think the data we've discussed naturally leads to some very uncomfortable questions.
Right. Think about the magnitude of what we just uncovered here. We now have this mountain of evidence, from observational cohorts to large-scale meta-analyses, showing that the epinephrine burden causes massive cellular toxicity, calcium overload, and a staggering 63% increase in recurrent cardiac arrest after we get a pulse back. If epinephrine is this toxic to a recovering heart, what does that imply about the massive milligram push doses of epinephrine we are currently slamming into patients during the actual CPR?
That is the exact question keeping resuscitation researchers awake at night right now.
Are we setting these hearts up to fail before we even get them back? Are the very medications we use to force a pulse return creating the massive instability we are then desperately trying to treat moments later?
It's a sobering thought.
It makes you look at that first fragile pulse in the emergency department a completely different way. You're no longer just relieved to feel it under your fingertips. You realize that keeping it might require doing the exact opposite of what you did to get it.
It forces us to constantly evaluate our core assumptions.
Keep questioning the defaults. Thanks for taking this deep dive with us.